Hello, and welcome to the Health and Productivity Management, Meeting the Needs of the Broker Consultant Community through Value-Based Design webinar. This is presented by the American College of Occupational and Environmental Medicine, the Integrated Benefits Institute, and the Center for Health Value Innovation. Today's program presents an overview of HPM, specific research studies detailing the impact of poor health on a company, an introduction to the HPM modeling, and measurement tools and key discussion strategies for brokers and consultants in designing value-based programs for improved health, health-related productivity, and financial trends. This program is being recorded. There is 1 hour of CME and MOC credit for this program. You received a verification form with today's instructions, or you can follow the link that was in the instructions. No certificates will be sent to you, but your transcripts of this and other ACOEM educational programs can be viewed and printed from the ACOEM website. Members and non-members can both view their transcripts directly from the website. Today's program will consist of approximately 45 minutes of lectures and questions at the end. We will address questions as time permits and suggest that you submit your questions early for consideration. We are only accepting questions electronically. On the screen, you can see how to open the question box in order to submit your questions. This was also included in the PDF file of your handouts you received with the instructions. We are very fortunate to have Dr. Ron Lupke, Dr. Jack Mahoney, and Cindy Nair as today's presenters. On behalf of the faculty and planning members, we would also like to announce the following disclosures. And at this time, I would like to turn the program over to Dr. Ron Lupke. Dr. Lupke, you may begin.
Thank you, and welcome everyone. We're excited to be able to present this today and look forward to actually some very active question and answer session towards the end. Go to the next slide. Let me begin by just providing a brief background overview of what we're talking about today. There's definitely change gathering on the horizon regarding our healthcare system, and there are many converging trends in the industry that are leading to a new value proposition that's emerging in the marketplace. That new value proposition is the business value of better health. And there's been a lot of discussion about value-based benefit design, and that's going to be linked to health and productivity today in the discussion. There's a growing body of scientific and economic evidence that can be used to build a sound business case for employers to invest in integrated health and productivity strategies. And those of you that are participating in today's webinar will be uniquely positioned to leverage that knowledge and apply those insights as you provide your clients the expanded value of enhancing health and improving productivity. The stakes could not be higher. We know that the health of the workforce is inextricably linked to the productivity of the workforce and therefore the health of the bottom line. And that employers really depend on the resiliency and productivity of their workforce to compete in a global economy. Michael Milken actually said that a 3% increase in human capital, this healthy human capital that we're talking about, would have offset all the financial capital losses in the global markets this past year. And the value-based designs of the future for corporate health strategies of employers will increasingly relate to leveraging the benefits of better health and productivity rather than merely managing the cost of the health insurance benefit. Next slide. So the problem, we all know, and I won't belabor, you'll have this information available to you, but the health crisis is really what has led to the cost crisis in this country. And 63% of medical cost increase over the past 5 years has really related to chronic illness. This increased burden of illness and increased burden of health risks that lead to chronic illness is what's driving these increased costs. The stunning impact, though, of the health risks are that 80% of heart disease and stroke, as well as 40% of cancer, are preventable, according to the Center for Disease Control, if Americans just stopped smoking, ate healthy, and exercised. And the challenge that we're dealing with as a country is that we have 80 million baby boomers that are coming into the age of entitlement with Medicare and Social Security, right at the same time that they're going to be needing to utilize the healthcare system that much more. And that's what I call the perfect storm with this silver tsunami of the age wave. Next slide. The bigger problem, though, for employers is the full cost of poor health. It's in an iceberg metaphor because the tip of the iceberg has typically been what they've looked at in the past, the medical pharmacy costs. But the bigger issues driving more of the costs are what's below the waterline, the health-related productivity losses, absenteeism from work, or presenteeism, where an employee is present at work but not as productive as they could be because of a health condition or health risk. And so even though in the past employers have used this radar to look at the medical pharmacy costs, now they need to look at sonar and look under the waterline at these health-related productivity costs, because we found in a study, next slide, multi-employer study of 10 employers that we did with ACOEM and Integrated Benefits Institute and Lear Center for Health Intelligence and Dr. Ron Kessler from Harvard Medical School. We found that for every $1 of medical pharmacy cost employers paid out, they were experiencing $2.30 of health-related productivity losses. Therefore, the 70-30 ratio on the iceberg. Next slide. And the top 10 conditions driving the medical pharmacy spend we're all very familiar with from looking at this in the past, with cancer being at the top of the list. But the next slide actually shows the top 10 conditions driving full cost are a new top 10 list. Depression is number 1 on that list when you add in presenteeism and absenteeism along with medical pharmacy spend. And obesity, number 2, arthritis, back and neck pain, anxiety, on down the list. So it adds a broader integrated health and productivity improvement strategy that employers are interested in focusing on. Next slide. On this slide, we actually have a specific employer example where they looked at their own data internally and broke it even into some more subcategories. The inpatient costs, other outpatient costs, emergency room, the drug spend, short-term disability, absenteeism, and presenteeism. And look at how presenteeism costs still dominate, even when the employers look at these other cost categories. But with similar full cost drivers in terms of the health conditions, depression being number 1. Next slide. There are tools out there, if you don't have data at a particular employer to analyze in this level of detail, there are some modeling tools that are available. These are just 3 among many. One is the Blueprint for Health. It's a framework for total cost impact, and it was sponsored by the American College of Occupational Environmental Medicine and the National Business Coalition on Health. It's a free web-based tool for making value-based decisions, and it's valuable to employers with or without expertise in data analysis and or employers who don't track absence or productivity in a formal way, and uses data methods and metrics derived from a large data set of U.S. employers so that you can estimate the total cost of healthcare, lost productivity, and absence. Another tool is the Health and Productivity Snapshot from Integrated Benefits Institute. And this is a tool that offers you a low-cost decision support system that requires just 10 readily accessible corporate descriptors. It's based on the HPQ, which is the Health and Work Performance Questionnaire developed by Dr. Ron Kessler out of Harvard. And the snapshot uses your company descriptors to model expected workforce health conditions, treatment status, absence, lost time from presenteeism, lost productivity, and the ultimate business impact for your company. In addition, another tool is the company-wide lost productivity calculator, and it estimates the cost of absence by determining an absence multiplier tailored for your company in your industry based on the methodology established by health economists Dr. Sean Nicholson and Dr. Mark Pauly. Next slide. So if these are the problems that we talked about in terms of full cost of poor health, then the solution is really reducing the burden of health risks and the burden of illness that can lead to a healthier population and measurable total cost decreases, because we have seen significant body of evidence in the research literature that medical costs, as well as presenteeism, absenteeism, and disability costs, follow health risks. In other words, as health risks go up, those costs go up. As health risks go down with interventions, those costs go down. Next slide. And we're also seeing attention by employers to this integrated whole person, whole population approach to enhance health, so that it's not just people on the right side of the continuum that have complex medical conditions or need disease management or condition management. It's moving upstream and keeping people healthy that are healthy on the left side of the continuum, or identifying those at risk and that need earlier detection and earlier intervention, which is secondary and tertiary prevention. Next slide. And this new value proposition that is emerging, the business value of health, is actually changing the discussion about ROI to VOI, the value of the investment, looking at a lot of different performance indicators that can be tracked and harness the full value of the intervention for improving health. Next slide. And one of those, we did an actual case study where we used the IBI Health and Productivity Snapshot and analyzed for an employer with 58,000 employees, modeled that they, on average, are probably losing 8 days of lost productivity per employee per year. Next slide. And that, for that employer, cost $153 million in lost productivity. Next slide. If they were able to just impact and get back 1 day out of those 8 days of current productivity lost per employee, that represents $18.8 million for that company's bottom line, their EBITDA, earnings before income tax, depreciation, and amortization. For them to get that same EBITDA impact of $18.8 million by growing top-line revenue, they'd have to grow their top-line revenue and sales of products by $76 million. Next slide. Now, the CFO of this company put it in even more salient terms in terms of shareholder value. And he said if they have the $18.8 million EBITDA impact, they trade at a 13-time multiple in Wall Street, so that's $244 million estimated market cap increase. And they have 292 million shares outstanding, so that's 84 cents in additional per share value if they can put health improvement programs in place that could get back just 1 day of the current 8 days of lost productivity in that population. Next slide. And then there's a study from the Watson Wyatt National Business Group on Health survey of 355 large employers that actually showed companies that put in place highly effective integrated health and productivity programs yield 20% more revenue per employee, 16% higher market value, and 57% higher shareholder returns. Next slide. So bottom line is that good health is good business. And at this point, turn it over to Cindy.
Thank you, Ron. And thank you all for being with us today. Very quickly, I'd like to tell you a little bit about the Center for Health Value Innovation. We're a fairly young organization, but we represent over 40 million lives. You can see on our board of directors some of the folks who are associated with us. These folks have joined the center to drive the value of every healthcare dollar that is being invested in their workforce today. Next slide, please. The health value continuum was a beginning construct to understand how people begin to adopt a value-based design, how companies begin to think about it and move into it. At the very beginning, it was a pretty erratic kind of a construct, but what we've learned in the 4 years that we've been surveying companies around value-based designs, we're very clear about the following things. First of all, that there is a very clear focus on prevention and wellness and a very clear philosophy that is an investment-based philosophy in the health and productivity management of their workforce. Secondly, that they have continuous quality improvement initiatives in place, and they're able to translate that into health and productivity management. And third, that they understand that by reducing risk, rather than reducing cost by cost shifting, they actually get more health and productivity out of their workforce and are able to continue to sustain the impact over time. Next, please. What we've now learned is that there's over 100 levers in the value-based toolkit. We've rolled them up into 15 macro levers, and those macro levers influence 3 basic buckets. The first entry point is waste reduction. Where are there folks who are not in the claims system at all, so they're not getting any care? And where are the folks that are in the claims system but using the resources inappropriately, either by extraneous use or by using, as an example, the emergency room instead of their primary care physician? But then they move very quickly into future risk reduction. So how do we use the health risk appraisal, the biometric screens, claims, disability data, and other data, and merge that to understand what is the risk, the compelling risk factors for the organization? And that is clearly where some of the tools that you've just heard from Ron that are available to all of you on the phone, those tools are available to help you quantify the trend and the opportunities for reducing the risk both at the person level and at the corporate level, and shifting left so that more people are reducing their total health risk profile and therefore reducing the impact to the corporation. When you begin to do that, you begin to actually install a culture of health in the corporation, which then builds individual competency for managing their own health and security. So what's the value of the 100 levers? This information will be published this spring, but we wanted you to know that we've surveyed the board directors, and what we've learned is when folks put in levers, and no one ever only does one lever, but when they put in a suite of levers that work towards individual health management, they've been able to reduce their health cost trend by 50% over 4 to 5 years. When they've done a condition management suite of levers, they've been able to reduce their health cost trends by up to 50%. And when they've done provider selection or care delivery levers, in other words, where do you get the care, they to date have been able to reduce their trends by about 35%. I want to give a caveat to that one. That trend line is only 2 years old. The other 2 trend lines are 5 years old, so we believe when we see a trend line for provider selection of 4 to 5 years, we will again match the 50% reduction. It's incredibly important that you understand no company ever only did one lever, and they always did levers across all of these different buckets. It's very important to understand that. So as you talk with your clients, you want to consider what's the total risk to their organization, where can you make early waste reduction impact, and then how do you begin to quantify the future risk and build individual competency so that there's mutual accountability. Next, this is the slide that is, again, modeled at a small employer from the Health and Productivity Snapshot. I want to call attention to 2 points. The first is their target productivity savings level. If they could reduce productivity impact by 1%, if you flip all the way to the last column, what they learned was they could actually increase FTEs by 3/4 of an FTE. What that meant to them, because this was a public sector company, is that they could actually deliver services to the community through a nurse practitioner or other kinds of community clinic events that would improve the health of the community. And that was so powerful to them. So I personally want to thank ACOEM and IBI, but I want to also encourage all of you on the phone to consider how you might use these tools. They are incredibly important for building the business case. And with that, we do have a couple of applications, one around individual health, one around care delivery, and one around condition management. Again, I want to be very clear. We literally have force-fed these companies into each of these buckets. All of these companies have done things across the buckets. Many of you know the stories around Pitney Bowes. I will let others talk to that story, but at the end of 5 years, they were able to manage to the goal that they set, which one of the goals was, how do we increase medication possession ratios around hypertension, asthma, and diabetes? They were able to achieve the gold standard of 80% of compliance in drugs for managing these high-cost conditions, and their total cost of the targeted conditions dropped. In the care delivery from Gulfstream, what they did was to go to the providers in their communities, ask them to practice to evidence-based guidelines, and with the production, they also then paid those providers, the hospital systems and the docs, more dollars at the end of the year on the E&M. And then what they did was they created incentives for the employees to use those higher performing docs in the hospital system, and they reduced the cost to use those docs. So in this particular case, the total incentives were aligned, and they got the results that you see here. In individual health, QuadMed, which is a wholly owned subsidiary of Quad Graphics, the largest four-color printer in the United States, they focused on the obesity epidemic in their population, and what they were able to showcase through a variety of levers was a reduction to 5% year-over-year trend over 7 years, and in 2006 actually had a negative trend. And with that, what I'd like to do is turn this over to the godfather of value-based design, Dr. Jack Mahoney, also one of the co-founders of the center.
Thank you, Cindy, and thank you to everybody for the opportunity to speak today. And I really feel old and tired when Cindy says godfather, but at any rate, I think the issue here is we've used the word value-based design a number of times in this conversation. What I'd like to do is spend some time with you just clarifying what do we mean by value-based design and what's different about this from what we do traditionally. And first, let me put something on the table. Value-based design is not about cutting copays. It's a much more focused strategy than that. So please park that concept and bear with me on a little bit of a journey. What is benefit design? Well, benefit design is really all about cost sharing, if you will. We define what we're going to cover, and then we define the cost sharing parameters around it. And cost sharing plays out in two very different ways. One is how do we influence what people will buy for coverage. For example, are they going to buy single coverage, family coverage? What are the cost implications of that? Or are they going to buy a high deductible plan versus a very rich HMO plan? So that's the first part. How do we influence the scope and type of coverage that an individual will purchase? Once we're there, plan design really comes down to how do we influence an individual's behavior within the plan. And frankly, it's been all about how do we conserve resources? How do we get the individual to, if you will, spend appropriately, to use the providers or network that has been set up for them? And frankly, it has been based very much on the acquisition cost of the service. So to put that in hard terms, and we all know this, if, for example, we have probably might have a lower copay for using a primary care physician than a specialist. We may have a lower copay or out-of-pocket exposure for using a walk-in clinic as opposed to an emergency room. And of course, we're all familiar with the multi-tier pharmacy design, again, built around what is the acquisition cost of that service. And the other part of it is that plan design is usually thought of as uniform across the population. We put it out there, it applies to everybody, so despite my individual condition, whether it's a medical condition or financial, I have to abide by that particular plan design. Well, the key question is, how did we get there? And believe it or not, there is a very good evidence-based study that was done quite a while ago, and it's called the RAND Health Insurance Experiment. And that was done in the early 70s when there was some question about the role of cost sharing and specifically people going into an HMO. What was fascinating about the study is that RAND was able to do a very large-scale population study. People were randomly assigned into one of 5 different medical plans, one of which was an HMO. The others involved cost sharing, and the cost sharing could go from 0 cost sharing all the way up to 95% cost sharing. So there was quite a spectrum. If you look at the timelines here, 71 to 82, you'll also know that these were all based on indemnity plans because in those years the concept of PPO or certainly a consumer-directed wasn't around. So think about coinsurance, traditional plan design, very, very different levels of out-of-pocket exposure for care. And the bottom line of what was looking for, the RAND experiment was looking for, was how did this influence the quality of care, the individual's behavior in using healthcare resources. So we look at some key findings, and you really don't need to be a rocket scientist to get the first bullet here. Some level of cost sharing influenced the individual's behavior. Specifically, people who paid a share of their healthcare costs used fewer resources than the people who had free healthcare. That is fairly obvious. What is very interesting, though, is that underneath that, the researchers found that people actually reduced all of their health care if they had cost sharing. So there wasn't a discrimination between what was going to be effective and non-effective. People just cut back across the board. They did find that there was no significant change in the quality of care received by the participants. And by doing physical exams, they were able to demonstrate that level of cost share had no adverse effect on the individual's health. So, if you will, that's been the visible part of the RAND experiment, and this is what is translated into plan design as we know it. I think the larger piece here, though, there's some underlying issues. Specifically, remember the time span, 1971 to 1982. Our tools for measuring quality and outcomes certainly weren't well developed in those years. They were, if I could use the word, primitive. Certainly preventive care wasn't a part of the repertoire of individual medical practice. Yes, it probably was incorporated on some level, but certainly not to the level it is today. What is buried in some of the findings is the fact that for certain people, free care actually produced better outcomes. And these were people with more severe illness or the people with lower financial means. And that's a separate discussion, if you will. But to me, the biggest thing here is we're not getting steerage to effective care. And to that extent, we're not getting an outcome that we are looking for. So in subsequent years, there have been some other studies that do say that with out-of-pocket expenses increasing based on the previous model, does it have a deleterious effect on a population? And there's a lot out there, and I've just pulled two different types of studies. The first one is in the medication area, and this was done by Dana Goldman, actually from RAND, and they did a meta-analysis of 132 peer-reviewed publications on the impact of out-of-exposure costs on people's possession rate of medication. And you can see the results here. For every 10% increase in out-of-pocket exposure, you can expect a 2 to 6% decrease in prescription drug spending. Well, that's an interesting tool to do plan design with, and certainly it's been used, but notice the second bullet. You get that decreased cost at the expense of the individual having access or using appropriate medication. So you get lower rates of treatment. People don't get their script filled on the front end. If they do get it filled, they don't get it filled continuously, so there isn't that persistency. So you get poor adherence, and you have discontinuation and poor outcome. Another way to look at this, and these are two studies, but they actually have the same impact, and it's the impact of cost sharing on preventive care. The first one is Medicare population, and just a modest increase in an out-of-pocket exposure, $10 or a 10% coinsurance level on mammography, decreased screening rates by a little more than 8%. A fairly significant finding. The second was in an employed population, actually was done through the Pacific Business Group on Health, and it showed that as you increase the cost screenings, again by the same level, either by a $10 increase or a 10% increase in coinsurance level, you saw decreases in access or use of preventive services. So preventive counseling is down. The mammography rate again goes down, as does pap smear screening. So in fact, the out-of-pocket exposure is going to have, by increasing it, we have a negative impact on health. So now how does this play in value-based? And I started at the very beginning in saying it's not all about copays. If you look at the first column there, financial design, that's really what we've been talking about, and it's the legacy of the traditional plan design out there, and you'll see the same things, conserving resources, management of each line. We all know that we carve up our benefit plans, so we're looking at medical versus pharmacy versus behavioral health, and then we have disability probably in a separate line, and absenteeism is probably poorly measured at best. But at any rate, people are managing each one of those line items. And I mentioned the cost sharing based on acquisition. If you'll just look at the top line across, here is the key strategy. Instead of looking at conserving resources, with a value-based design, we're looking at outcomes. How do you get the best possible outcome in terms of improved functional health? Because I think what we've heard from the previous speakers is it's that functional health that's going to drive the real return for the employer. So if I could leave you with one thought, primary thought, it's value-based design is all about outcomes. The rest of these are tactics, if you will. You're looking at within value-based design, you're looking at a total cost picture. So instead of fragmenting the pie, let's put it all together. So we're looking at both the direct cost and, very importantly, I think especially with Ron's slides, you see the importance of looking at those indirect costs, because indeed those may swamp the total direct costs of care. The nuance in the value-based design is saying, okay, if we're looking at the outcome, let's invest in effective resources. And that can be from a number of different perspectives. One is actually putting those effective resources into the array of services that we provide in a benefit design. And then once there, subsidizing them at a much higher level. So in other words, decreasing the out-of-pocket exposure. So we have a financial steerage of people to the resources that we think are going to be effective. And the reciprocal of that is perhaps maybe subsidizing less effective treatments or medications, resources at a lower level, so that we have a financial steerage mechanism built into the plan design. And the last piece is that it may be that we want to vary a support of the individual or decrease out-of-pocket based on a medical condition. So the example here would be, we all know that statins are effective in decreasing LDL levels and total cholesterol, but it's one thing to do that as a primary prevention measure. It's very different to do it as secondary prevention for a person who's at high cardiac risk. For example, the person who's a diabetic or who's already had a cardiac event. So maybe we would say that based on the perceived efficacy, we would want to subsidize the statin for the person at high risk at a different level than subsidizing it for a primary preventive vehicle. So if you will, if you read from top to bottom, you're looking at strategy and then some of the tactics that are involved in value-based. And it really does tie quite nicely then into how do we improve the health and productivity of the individual. So when we're looking at this, I've talked about plan design. And not to be overly technical, but plan design results in a medical plan that an individual signs up for, in essence, is a contract between the plan sponsor and the individual. That has some limitations because you can only change it annually or, if you will, by doing a re-enrollment. The other vehicle which is out there, which is heavily used, are incentives, and we've all used them. To get somebody to take their health risk appraisal, we may give them a financial incentive. To have somebody participate in a given program, we can use an incentive. And the specific point here is that they operate outside the benefit design, but certainly they complement a benefit design. You can initiate them, modify or terminate at any time by the plan sponsor. They do have some financial overhead. But I mentioned the targets, and you can target them very effectively. A variable reward structure. Minimal regulatory structure. So we're not talking about plan design. And interestingly, there is a regulatory structure here. Under HIPAA, the value of your incentives can't exceed 20% of the value of the plan for the individual. If you've noticed any of the legislation, the proposed legislation that's coming out of Washington, most of the bills do increase that, so there may be some more leeway to that. How does all this work together? Well, we talked about plan design, we've talked about incentives. These aren't things that should be done in a vacuum. Cindy mentioned data, and I can't emphasize too much the value of data. None of these changes, whether it's a plan design change or an incentive implementation, should be done without firm data on the population. What are the population needs? What are the gaps? And specifically, what are the outcomes or objectives that you're aiming for? But once that's put together, then one can then use those two vehicles to incent people to use the appropriate resources that are out there. And these may be programs, plans, providers, or treatments that you want people to use, again, for that effective outcome. And in doing that, Cindy used the same categories, and I just want to reemphasize it, that the value base can be focused on improving personal health. You can be looking at long-term condition management, or you can be looking at care delivery and quality of care. So, what's in it for the plan sponsor here? Well, obviously, the first thing is if you get people to effective care, then hopefully you've got the improved compliance with the evidence-based care and definitely the improved functional status of the population. There's a potential for the direct and indirect savings. What is interesting about the design is it can also be expected to drive greater employee engagement in managing their care, because if they're beginning to make some decisions based on the resources that they're using, hopefully both they are getting engaged, and it can be a very interesting vehicle for engaging the provider community. So you get a partnership. So the bridge here takes you into things like pay for performance, bridges to excellence type of program. The implications for the plan sponsor? Well, whenever you talk about investment or an ROI, there is that word investment in there. An investment means dollars. So there may be some additional dollars on the front end. And this can take various forms. It can be increased medical plan expenses, the pharmacy. You can see the whole piece here. Bear in mind that these additional costs have to be looked at in terms of a broad or a longer-term view. Could have implications for which health plan or providers that you're working with. Has some legal implications. There's always concern about HIPAA and data sharing, especially when you get into medical condition-specific design. However, I've talked to a number of employers who have implemented this type of plan, and it really hasn't been an issue. There are ways to address this so that you are fully HIPAA compliant and protect the privacy. And the issue that usually comes up are the HR issues. There is a concern that some employees will feel that other employees are getting, quote, a better deal, unquote, through a value-based design. The harsh reality, again, in talking to as many plan sponsors as I could, is that it hasn't happened yet. people just aren't surfacing this type of issue, and there seems to be an understanding that when people do get a more favorable treatment, for example, a lower out-of-pocket exposure, it is related to their health. So, in summary, I'd say that there are a lot of very difficult decisions that are sitting out there. We've heard, especially today, about the impact of productivity, and one of the tools that may be appropriate here is a value-based benefit design, and it really does involve investing in health, looking at that outcome, which is improved functional health, and helping people to make the right choices within the resources that are available to them.
Turn it back over.
So at this point, to qualify for continuing education, we're going to address a few MOC questions to our presenters. Please comment, true or false, personal health costs, medical and pharmacy claims account for only 30% of the total health-related costs to employers. Can our presenters please respond?
Well, that's true. It's the iceberg slide that we talked about, and in the study that showed for every $1 of medical pharmacy costs, there are $2 to $3 of health-related.
Group with free care.
And that would be true. It is one of the direct findings from the RAND Health Insurance Experiment.
And finally,
And it would be E, all of the above.
at this time, we have time for
Year to year, or is it an overall reduction?
It's a really good question. It's an overall reduction across 4 to 5 years. So what we see is that the initial reduction is actually quite small in the first year, usually, and that it escalates the longer folks have the value-based design in place.
Okay, thank you. And then next question is, are the 100 levers based on the case studies and or user submission online? And are they only available from the upcoming book?
I'll handle that one again. First of all, what's in the upcoming book are the 15 macro levers, and you will see 8 case studies and how they used the different levers in their ability to manage their health cost trend and improve outcomes. The 100 levers are changing almost daily as we get more and more information. So as folks fill out the online survey, as we do case studies, and we also do surveys in different cities and through coalitions, we're updating the levers at all times. But what we found is they have not changed in the 3 major buckets: the waste reduction, future risk reduction, and then individual health competency.
we did have another question submitted. How can we begin to discuss these concepts with smaller employers, for example, 100 to 500 employees, and keep their attention?
I'll go ahead and answer that one. I actually worked with quite a few brokers and consultants yesterday. This is exactly the right question, because most of America, 98% of America, works in a company under 200 employees. It's incredibly important that we get this information to them. But we're also up against an interesting conundrum in that most of those employers are also not self-insured. They're fully insured. And so what we're doing is we're working in tangent with the health plans, the health insurance companies, to begin to share data across benchmark. So in other words, if you're fully insured, you might not be able to get your own data, but how you might look at the data from the insurance company through their book of business. This is where the broker-consultant community becomes incredibly important. So how might you look at the data across your book of business? And then where might you map it, as an example, with the Health and Productivity Snapshot in a larger aggregate. So if you have 200 to 500 people that you can pull together, 200 to 500 employees across several of your customers, how you might aggregate that data and use the Health and Productivity Snapshot to get an idea of geographically what are the key issues and where should you be focusing. Again, I cannot reiterate, re-emphasize enough. If you continue to look at the medical and pharmaceutical cost spend, you will continue to see health cost trends go up. You may get a year's respite, but it will go back up in the following year. We've got to get focused on outcomes, and outcomes are totally dependent on looking at the total cost. You on the phone have the ability to make that happen.
I'd also like to ask Jack or Cindy, as you saw from the study that we did at ACOEM IBI, the top 10 conditions driving full cost, depression was number one on that list. And I know you all have done similar types of analysis and found that that's an area that needs to be addressed more. We've talked a lot today about some medication adherence and other things that are looked at in the value approach. Say a little more about both depression, and then number two on the list was obesity. And so what are some of the kinds of issues that need to be addressed? What are some of the kinds of incentives that employers are considering to begin to address those two conditions?
Can I take those in reverse?
Yeah, sure.
Because obesity is very interesting. We talk about it. We talk about the need for people to take control of their weight. If we look at a typical medical plan design, typically we're not covering nutritional counseling. We're typically not covering exercise. Maybe it's an incented activity, but it's not something that we're going after in a big way. And third, we're treating all of the, if you will, sequelae of the obesity, which can be hypertension, hyperlipidemia, cardiovascular disease, possibly diabetes, as standalone illnesses. I think that if we were to reverse that process, and I have actually seen a value-based obesity plan proposed, it really is focusing on what is the totality. Remember the piece up here of looking at total costs, not individual. But one of the things that we have to be careful of in healthcare is not parsing the individual by condition. Look at it as a total. So if we look at that total, and then look at what are the resources that that person needs in order to be successful or be effective. And so here again is an example of, well, maybe we don't want to subsidize nutrition counseling for our entire population, but for this at-risk population, maybe we want to subsidize that. Maybe we want to facilitate access to, and here's the link, within obesity, there's a high comorbidity of depression. Maybe we need to facilitate access to psychological services and screening. So that would be my response in the obesity. For the depression, again, we tend to compartmentalize this, and I guess I'm showing my age at this point. We used to have a broad-based preventive program out there for a lot of behavioral disease, and it was called EAP. And it was, depending on the model, multiple sessions, free access to a mental health professional to help people at least understand their condition and maybe get short-term resolution. The fascinating number to me is 10 years ago we did a study, and it was close to 80% of problems are solved in 6 or fewer outpatient sessions. And unfortunately, again, we've looked at EAP as a benefit. We put it into that grid and looked at how do we conserve resources. And it's not unusual now to find an EAP program that's a 2-session free, maybe a 1 session with a referral to behavioral health care benefit, et cetera. So again, it's looking at what's your outcome. You want to get the person back to functional health. What's the best way to look at it? And that is, how do I facilitate access to the effective service, decreasing the out-of-pocket exposure, and then meeting the person's need. That's not going to solve all of the depression, but it certainly is going to provide people with quicker, easier access to professional care.
That's a great answer. In fact, another finding in our study was that so many people have multiple comorbid conditions that if they have even one chronic condition, 93% of the study population had more than one. Yeah. And as you watched it go up to even 10 conditions in some people, there was dramatic impact on their absenteeism and their presenteeism, obviously. And in the solutions that come forward, it seems to be that we need to have integrated solutions instead of just a depression management program or a diabetes management program or a obesity program. We need to have integrated solutions that deal with the whole person.
Yep.
And I did have a patient say, just to affect what you mentioned, that when the employer carved out to a diabetes company or to an EAP or to a work comp claims person, she felt carved up.
Mm-hmm. Mm-hmm.
Said, my pancreas goes to the diabetes plan, the hip goes to the AP, and the rest goes to the work. And they don't talk with each other. They don't coordinate.
Right.
And I'm getting conflicting messages. I give up, doctor. What should I do?
Right.
So I think integration and integrated health improvement strategies are really a key to this promulgation of value-based benefit.
If I could just hit on that one as well, Ron, I think the other piece of that in the integration is making sure that the purchaser, whether it's the broker, the health plan, or the employer, is holding all of those vendors accountable and requiring them to have the discussion at the person level.
Yeah.
And HIPAA can all be in place to make sure that the privacy is maintained, but the opportunity is not in carving up people and trying to solve for lab values. The opportunity is in solving for a health and productivity outcome at the person level that's relevant to that person, working on what they want to work on. That's how we'll get them to change their behavior.
Right.
We have time for just one more question. And the question submitted is, focusing on value-based design seems to bring creative and practical solutions together with win-win for brokers, employers, and health-related companies. Where do you see the biggest push or demand for value-based initiatives? Are employer groups recognizing the need?
The largest push, and we hope that the largest push will remain this way for a long time, is in prevention and wellness. We need to stop focusing on disease in this country. That drives a sick care answer. What we need to start focusing on is prevention and wellness and reducing the total risk, because by reducing the total risks, by shifting left, we can actually not only create health and productivity improvement, we can really substantiate and measure economic improvement at the individual level, at the corporate level, and at the community level. And that's how we will regain our superiority in global competitiveness.
Could I answer that in a somewhat different vein? I've had the opportunity to be around the country and talk to a lot of employer groups. And it's fascinating to me that the biggest interest in this is not really the big employer. It's the small to medium-sized employer. They're closer to their employees. They understand the negative impact of poor health on the performance of the company. They are very interested in doing something, and at least initially they were frightened by value-based because the concept was it could only be done by a mega company who was fully self-funded, who had influence over the claims payers. That's really not true. I think what we've tried to leave you with today is the idea that there are many different things that can be done. Some can be done through individual. They're more potent if done in collaboration with other employers, and they can be accomplished in the fully insured environment.
Yeah, thank you, Cindy. Thank you, Jack. I would just say in summary, this verge of witnessing these inadequate levies of our reactive illness-oriented sick care system, as you mentioned, Cindy, to break apart from that flood of chronic illness and overwhelm individuals and communities, and could lead to a profound change in the economic landscape for business and industry, ultimately for our government. However, as you've heard today, there are innovative, integrated, value-based population health and productivity enhancement solutions that are emerging and can ultimately hold back that surge. I would say the healthcare cost conundrums that we face can positively be impacted by these solutions and drain the floodwaters of that chronic illness and go upstream and reduce the health risks from developing those chronic illnesses in the first place. In fact, the broader value proposition of integrated population health and productivity enhancement is driving these strategies by leveraging the value of health and the power of prevention. And I would submit we are on the threshold of the transformation of our system beyond being so reactive and illness-oriented to becoming much more proactive and wellness-oriented as a true health system. Thank you.
On behalf of the American College of Occupational and Environmental Medicine, the Integrated Benefits Institute, and Center for Health Value Innovation, I'd like to thank all of you for your attendance, and thank you to our presenters for their valuable presentation. This concludes today's program. You may disconnect.